afternoon, everybody, from a sunny Johannesburg. Welcome to today's webinar, an essential platform to discuss innovative approaches to combat the critical issue of maternal mortality in Africa. The theme of today's session addresses a critical challenge: reducing maternal mortality through sustainable, community-driven strategies and innovations. The past 20 years have seen a significant decline in maternal mortality. Despite this progress, it's estimated that a maternal death occurs almost every 2 minutes. Maternal mortality rates in sub-Saharan Africa remain particularly high. The region accounts for more than 70% of the world's maternal deaths. Most of these deaths are preventable. Today's webinar aims to explore practical solutions by learning from success stories and examining innovative approaches that can drive substantial change. We are honored to have a distinguished group of thought leaders and health professionals joining us today, all committed to improving maternal health. In this session, we'll gain practical knowledge on structuring health systems to save lives and reduce maternal mortality. We'll explore successful models from various contexts, discuss how challenges have been overcome, and chart a way forward for improving maternal healthcare across the continent. We love interacting with all of you, so please use the chat functions to let us know who you are and where you are joining us from. Also, feel free to use the Q&A functions for any questions you might have for our speakers throughout the session. And with that said, I'd like to introduce our first speaker, Prof. Jude Igumbo. He's a leading digital health advocate and developer. He will present updates on the Dima Health platform, including a live demonstration on its latest innovations. This will be followed by a brief Q&A session. Prof, if you're ready, over to you.
Great. Ina, can you hear me?
Yes, I can hear you.
Great. Thanks a lot. Today's presentation, we'll start with a 6-minute video. And after that, I'll provide updates on the platform. But I want to first of all thank you for organizing this, and as well as all who have joined us. Without taking more time, if I go straight to the presentation, now I'll start the video.
The Dima Health platform is a comprehensive digital solution designed to improve maternal and child health outcomes in Africa by addressing key challenges in healthcare delivery. With a suite of innovative features, the platform empowers healthcare providers, policymakers, researchers, and communities by offering tools that enhance access to healthcare services, promote evidence-based practices, and foster collaboration across the maternal healthcare ecosystem. Here are the key features of the platform, designed to address critical gaps and improve the overall quality of maternal and child healthcare. This feature provides in-depth socio-demographic and geographical data for various countries, including population density, health indicators, and economic factors, all relevant to maternal and child health. The maps are fully integrated with Google, allowing users to search specific locations and visualize key health data. AI-powered insights help interpret the data, identifying hotspots where interventions may be needed. This feature allows healthcare providers, researchers, and policymakers to understand the regional context of healthcare needs, tailor services accordingly, and better allocate resources to areas with the most significant challenges. The platform simplifies complex research findings into clear, actionable insights, tailored for healthcare providers, policymakers, and communities. A curated list of academic papers and health reports is available with advanced search and filter options. Summaries of these publications are available in multiple languages and formats, including downloadable audio versions. By making research accessible and actionable, this feature bridges the gap between academic findings and practical healthcare application, ensuring that the latest evidence-based practices are implemented in the field. This AI-enabled tool predicts and tracks the likelihood of early antenatal care or ANC bookings based on local health data and patient information. It provides healthcare providers with insights into booking trends and highlights areas that need improvement. The tracker can also forecast future ANC booking rates and help set targets for improving maternal care. Early antenatal care is crucial for preventing maternal and neonatal complications. This tool supports healthcare providers in ensuring timely intervention, ultimately reducing maternal and infant mortality. A comprehensive directory of healthcare services, including hospitals, clinics, maternal health programs, and community health centers. Our system currently has over 70,000 listed health facilities in South Africa, Kenya, and Nigeria. The directory also lists care providers, such as community health workers, making it easier for users to find the appropriate services near them. This directory can be used for both patient referrals and self-navigation. Simplified access to healthcare services promotes greater utilization of available resources, improving maternal healthcare access and outcomes. This feature allows users to rate and review healthcare facilities and providers based on their experiences. Healthcare providers can respond to feedback and receive AI-driven recommendations for service improvement. The system tracks these improvements over time, providing regular reports on service quality. Feedback mechanisms encourage continuous improvement in healthcare delivery, fostering greater accountability and ensuring higher standards of care for patients. A user-friendly system that allows patients to book appointments for maternal health services. An SMS-based option is available for patients in areas with limited internet access, enabling easy booking, confirmation, and appointment reminders. Streamlining the appointment process reduces waiting times and ensures better resource management, improving patient satisfaction and access to healthcare services. Safe Passage connects expectant mothers with safe and reliable transportation options to healthcare facilities for antenatal, delivery, and postnatal visits. This service is particularly important in places where transportation barriers limit access to maternal health care. By addressing transportation challenges, Safe Passage ensures that expectant mothers can access timely and critical healthcare services, reducing the risk of maternal mortality in underserved regions. The Innovation Handbook provides a curated collection of maternal and child health innovations, best practices, and solutions from around the world. It serves as a resource for healthcare providers, researchers, and policymakers to explore new technologies and methods. This resource encourages the adoption of proven solutions and fosters innovation in healthcare delivery, helping to improve maternal and child health outcomes through the latest advancements in the field. This feature connects healthcare providers, researchers, policymakers, and other key stakeholders in maternal and child health. Through discussion forums and secure breakaway rooms, users can collaborate on solutions, share challenges, and exchange ideas. Creating a strong network of stakeholders encourages knowledge sharing, collaboration, and co-creation of solutions that lead to improved maternal health outcomes across regions. A secure private messaging system that allows users to communicate with healthcare providers, experts, and other users, ensuring privacy and confidentiality in sensitive health-related discussions. Secure communication is essential for maintaining trust and protecting sensitive health information, fostering better relationships between healthcare providers and patients. The DEMA Academy offers accredited training and professional development courses for healthcare workers, community health advocates, and other stakeholders. Courses cover various topics, including maternal health, risk management, and innovations in healthcare delivery. Continuous education and training are critical to improving healthcare quality. The DEMA Academy equips healthcare professionals with up-to-date knowledge and skills, leading to better outcomes in maternal and child health. The DEMA Health Platform is a powerful tool for transforming maternal and child healthcare in Africa. By offering a wide range of features designed to improve access to services, enhance evidence-based practices, and facilitate collaboration, it addresses key challenges in healthcare delivery. Each feature adds value by improving the quality of care, promoting timely interventions, and ensuring that healthcare providers, policymakers, and communities can work together to achieve better maternal and child health outcomes.
Thanks everybody for listening to the short video, and that is what most of you know that we have on the platform, and I'm hoping that this is a quick introduction to some of you who have joined us for the first time. But since we produced that video, we've been doing some extra work to expand the utility of the platform, and those extra features I'll show in a moment. Before I move to the website to demonstrate these extra features, what you're seeing on your screen are things we have just described in the short video. And on top of that, there is a resource we're developing called the Safe Passage. This is being built as a transport system that is reliable, very affordable, and also looking at multiple ways we can make this resource available to people, but more importantly, creating transport means for different locations that are appropriate for their various locations. And in addition to that, we have the climate resilience component that we are also building on top of the app that I will show you all in a moment. If I go to the next slide, by the end of this month, by our next webinar at least, we would have a more robust platform and profile of health facilities, all of them across South Africa. And we are hoping that the new platform and profile of health facilities that we will collect will be such that it helps with finding health services, but also tracking resources, and also being able to link people to various opportunities around them would help us improve access to health services. So the new platform for health services will look like this. There will be the QR code that will be used for either booking appointments or for providing reviews to health services received. And almost everything that you've seen on our platform is available on the website. It's available on via SMS, and it's also available on a mobile application that is currently on Apple Store, but in the next coming weeks, we will have it on Google Play Store as well. So these are some of the things, improvements I will be having on the profiles of health facilities. I already mentioned in the video that these health facilities, we have managed to curate or collect and profile about 25,000 health facilities and pharmacies across South Africa. This includes public-private pharmacies and various laboratories as well. So we have all of them on the one platform. The climate resilience component really is hoping that it will help us understand how climate could be affecting access to health services and how we can create a health system that is more resilient to it. And most of the tools that we're also building on the system are also tools that would need this climate information to be to function more effectively. Our Safe Passage program, which is a transport system, that, for instance, will require climate data to help plan routes and avoid times when routes may be flooded or rivers may be flooded or too muddy for people to access health services. And by so doing, use that same information to rebook health services for patients who may have been booked to go to a particular clinic and may have missed it as a result of climate factors. And many other things that we can do with climate data. I won't go into all of them in the interest of time, but this information definitely will help us become more resilient to dealing with the implications of weather on accessing health services, particularly in areas where this becomes a big problem, which is often the remote areas that are historically challenging to reach. If you allow me a moment, I'll now show what the appointment booking system looks like. And as I've already mentioned, the appointment booking system is one that can be accessed both online using SMSs and also using SMSs and also using the mobile application to book. And why we make SMSs very important is because As we all know, that not everybody has access to a mobile phone. So those who don't have access to a mobile phone would at least have access to, would at least be able, could be assisted to use a toll-free SMSing system to book services or call a transportation either for routine care or in the case of emergency. So on the system, you have a list of health facilities from across. And what it would then look like is if you select a particular health facility, which can also be done based on Google integration to find those that are closest to you. By clicking on the health facility you've selected, it gives you what the address is. You scroll down to select the particular health service you want to receive. You choose the date where you want to go for it. Choose a time that you prefer, for instance, and you book your appointment. It's as simple as that. And once that is done, the appointment is booked. And in this case, if I then go to my appointment, I have a maternal health appointment in a particular health facility at that given time. In this current instance, transport has not yet been booked. By clicking next, you are automatically linked with a transport service provider. Come the day of the visit, you'll be reminded of the appointment a day before and a few hours before the meeting, before the appointment as well. And when the time comes, it will also help you track where the driver is. And if you've gotten into the car, it also shows both the healthcare provider and also other people that may have access to your information that you are on your way. But these are things that you probably could provide access to maybe a loved one or somebody who at least monitors your trip. When you arrive, the system is able to show, and when you are in a clinic, it shows that you're in a clinic, and when you're done, it's also able to show that you can now book, you are now scheduled for a return visit. And after scheduling for a return visit, the driver is on their way, driver arrived, your trip is ongoing and your trip is completed. So these are how we are hoping to track this all the use of the transport system, but also the booking system. We're hoping that when the time comes, more consultation would happen to get more insight and more input on how we can make this work best. But we're hoping that it will help improve access to health service, particularly in case of emergencies, where you need to move a person from one point to the other and there is no transportation. And even in that instance, as you've already seen, our academy would also provide a training program for the drivers, and the process of registering locations and drivers would also go through a bit of a rigorous process to ensure that there is safety and protection for those who use various services on the system. So these are some of the things that we are planning, and what we have already been able to do. What we are calling on partners to do is to join us on this journey in rolling this out and making it work for various locations where this may be useful. So I'll stop for that and happy to engage more either in this meeting or out of this meeting on some of these resources that we have created. I'll stop sharing so that we can prepare for the next presentation. But Ina, back to you. If there's time for questions, I'm happy to take that. Sorry, I didn't know that my video was off the whole time.
There we go. Prof, thank you very much for that insightful presentation. I just have a question with regards to these booking and transport services that you're hoping to roll out. Do you have any idea as to who would carry the costs?
Yes, so we have some ideas about a funding model. And that funding model is one that takes into consideration that not everybody can afford to pay for it. And we have listed a couple of income streams that we would then have to discuss with the major provider and payer of health services, which is governments of various countries, to say if we're to roll it out in your country, what would be the most effective way. Things such as microinsurance, a minimum fee with extended value benefits for those who use the system. We have we also plan to reach out to private foundations and donors. We also hoping to have tax incentives for private donors as well. So there's a whole basket of a whole basket of funding streams that we are considering. They're hoping to use this to pull enough funding. But again, if we think of what the demand looks like in area of maternal and child health only, there is more than enough opportunity to pull that funding together. For instance, in sub-Saharan Africa, we know that each year we have more than 50 million women who are pregnant. And of that population, close to 20% of them suffer one complication or the other. And we know what this costs. It runs into tens of billions on a yearly basis. So if we're able to provide this basket of solutions that help address most of these issues, we can then even begin to think about the cost benefits in making our case to government and other donors who could come on board to support this. But yes, we want to reach the poorest of the poor with this, and we would hope to use our various income streams to make this as affordable as possible for everybody. Thank you.
And how can partners or potential partners get involved?
We don't have answers to all that we are doing. I think starting with a conversation for those who are willing to partner with us would be a good place to start. We'll share our thoughts, and post that we then get their own input of how they can, come on board. But again, we're looking for funders, we're looking for access to communities, we're looking for visibility, connections to funding opportunities, and governments who are willing to experiment with us. And at the end of the day, this is going to be a truly African solution, built locally to respond to local needs, whereby if this were to be Uber for health services, such a system will be one that takes consideration of the kind of limitations in our system, such as poor transport systems, insufficient, quality or standard of vehicles that we need for this, and how do we take all that into consideration? So we're looking for partners to work with from end to end. We don't have answers to any of this, but we are capable to build a platform to set up the logistics and to ensure that it happens safely and securely.
That sounds so good. And Prof, I would assume that the contact details where people can reach you would be available on your website, the link that we've shared in the chat?
Correct. I'll also paste all that information in the chat further for those who want to reach us as well. Perfect.
Thank you very much, Prof. I'd like to talk to you longer, but we have to move on to our next speaker, please. So allow me to introduce our keynote speaker for today. We are honored to welcome Professor Lawrence Chauke. He's a distinguished academic and researcher at the University of Witwatersrand in Johannesburg. He serves as the Assistant Head of School of Clinical Medicine and the Head of the Department of Obstetrics and Gynecology at Charlotte Maxeke Academic Hospital, also in Joburg. Prof. Chauke has made significant contributions to advancing maternal and child health, particularly in low and middle income countries. His research focuses on key areas such as pregnancy outcomes. Prof has also conducted pivotal studies on the impact of COVID-19 on maternal health. His research has offered critical insights into maternal mortality and the management of pregnancy complications during the pandemic. I could read Prof's bio for a lot longer, but let's leave space for Prof to submit to do his presentation. In the meantime, please remember to submit your questions in the chat, and we'll try to address them all in the allocated time. Prof Chauke, the floor is yours.
Thank you very much, Ina, for the kind introduction.
Prof, sorry, Prof, to interrupt you. You are just appearing on the side of my screen. Could you either move to the center or move your camera? There. There you go. That's a little bit more. A little bit more. More. There you go. That's better.
Okay.
Thank you.
Thank you very much, and for the kind introduction, and to Prof for the invitation, and to all the colleagues online who have joined this webinar. I think there's never been an appropriate moment to talk about the impact of the health system as a tool to combat maternal mortality like now. And the reason for that is we are almost 6 years before the Sustainable Development Goals. And I think all of us are quite concerned about the probability that we might have a repeat of the Millennium Development Goal, where most of the countries failed to meet the target, and especially in sub-Saharan Africa. So I think, having said that, it's appropriate for us to look at how we can use the health system to try and accelerate the race towards reducing maternal mortality. And you will see why I say this as we start going through. I have nothing to disclose. I'm going to already given a brief introduction. I will then proceed to talk about why maternal death matters, and also look at why women are dying. Then I'm going to address the issue of whether it is possible for the world to achieve the SDG 3.1 goal, which is reduce maternal mortality to less than 70 per 100,000 live births by the year 2030. And then we're going to look at lessons that we have learned in the different countries. I will select few because of time, and from the evidence that's available there in terms of reducing maternal mortality. And I will conclude by reflecting on where we are and suggest the way forward. It's quite sober to start this presentation by reminding everyone in this platform that in the year 2020, 800 women died every day. And that translates to 1 woman every 2 minutes. And you can understand the magnitude of that problem. But what's ever also important is to know that most of these deaths are preventable. And they are related to condition or complication that has to do with pregnancy. Sad to say is that most of those complications do have low cost and evidence-based solutions that are easily accessible to even low-income countries. And yet, women continue to die. And I think that brings us to this second issue of why is maternal death an issue? I think you agree with me that each one of us have got the right to life. And I think women have been given that natural capability to bring forth lives. And it's our duty to make sure that we preserve their right to live, but also to give birth safely. And that's what makes maternal death such an important public health issue. But even more important is to know that maternal death is actually an indicator of the quality and functioning of a health system. So if you want to know how well the health system functions in a particular country, you just need to look no further than maternal death. Maternal death has got serious social impact to the families and affected children. If you look at the data, an orphan child that has lost the mother is likely to die before the age of 5. Most of them are likely to end up dropping from school much earlier. Others are likely to get involved in drug abuse, and that continues forever. And what it tells you is that once you lose a mother, you're already on the track of challenges as an individual, but also you are already on the path of struggling in terms of not making it in life and being or struggling in terms of getting yourself either in behavioral issues, but also on the economic platform. So maternal death really, if you look at it, is an indicator of the social and gender inequality. It actually tells you how society views women and the investment that we make coming out of that value system. So if you look at what are the main causes of maternal death, you can see that 70 to 75% are things that are directly related to pregnancy, or what we call direct causes. In other words, these are conditions that comes from the fact that a woman is pregnant. So for example, the most common leading cause are hemorrhages during pregnancy, complications of hypertensive disorders of pregnancy, complications of labor and delivery, infections, more especially in the postpartum period or post-delivery, and complications of unsafe abortion. The indirect causes contribute around 25%. And here we're looking at conditions like HIV and AIDS, pre-existing medical condition, as well as surgical condition. So by looking at the slide, you will realize that the bulk of the cause of maternal death are things that we all know of, that occur every day, that have got solutions that are accessible, and that have got solutions that can be afforded by many of the countries, even in low-income settings. Here's an example of the solutions that are available there to try and prevent some of these conditions, or even to treat them. I'm not going to go to this because I think we all know about this. You know, the use of oxytocin, that you can reduce. If you give prophylaxis oxytocin, you will reduce PPH or postpartum hemorrhage by 50%. You know, misoprostol, we know that you can reduce the risk of and need of blood transfusion. And this is recommended when oxytocin is not available. And what about calcium supplementation? We all know the case of preeclampsia and commercial hypertension, that it does have an impact, can halve the risk of preeclampsia in women. Aspirin supplementation, it's very easy. You can go to any shop, it's over the counter, but it has got huge impact. And looking at the data, it varies somewhere between 15 to 50% reduction in the risk of developing hypertension. And of course, I don't need to talk about magnesium sulfate and the issue of prophylactic antibiotics during cesarean section. So if you look at all those interventions, these are things that are cheap, things that are available. If I go out of my office today and look for this in the hospital, I'm more likely to find it. But the question is, if these things are available and they're easily accessible, why are women still dying? And I think this brings us to the barriers that prevent women from accessing these life-saving interventions. And I think there is no better framework to look at than the 3 delay model by Thaddeus and May, which I'm sure most of us in this platform knows about. But maybe just to remind all of us that it's got 3 levels of delay. The first delay is women deciding to seek care. And that has to do with socioeconomic, cultural, and personal factors. So for example, you find that in societies, a woman cannot go and seek help without seeking permission from somebody else. Sometimes just the pure of education and not appreciating the severity of the condition that they have. The second delay is identifying and reaching healthcare facilities. And I think that's where the health system comes into play. Because even if a woman decides to seek help, they've got that knowledge and education, there must be some health facilities that they're able to access. But if it's not available, there's nothing that they can do even when they need help. So really it's an issue about availability in terms of distance, accessibility in terms of road infrastructure, as well as availability of transport. And then the third delay, which is most worrying, is after they have managed to overcome all these, the first and second delay, then they come to our health facilities. Then the question will be, do they receive care in a timely manner? And is it appropriate for their condition? And is it of good quality? And I think those are the issues that we all need to ask ourselves in terms of making accessible those interventions that I showed in the previous slides, which are always there, or they should be there in most cases, not always there, and I'm going to talk about it in a moment. So having said that, we are now racing, we have made commitment in 2015 that we're going to reduce maternal death by less than 70 per 100,000 by 2030. But when you look at the data, and you're looking from 2015, the maternal mortality rate in 2015, global, was 227. And in 2023, if you look at the data last year, the global maternal mortality rate was 223. So you can actually see that the shift was not significant. Of course, we know that COVID came around and it did have an impact. So as we stand now, globally, for us to reach that target of less than 70, we need to have a reduction in the global maternal mortality rate of 11.6%. And the question is, can we achieve this? I look at the data of what was going on up to 2020, because 2020 is just when we actually started having a challenge in terms of COVID. So if you look at Oceania, Europe, North America, South America, and Asia, you can see that these countries were on a downward trend. And probably if COVID has not come, they probably will be on track to reduce maternal mortality. But look at Africa. Even before COVID came, we're already struggling. So if you take Africa as a whole, you can see that we really have been struggling. There was not much movement going on. And the question is, are we going to achieve this? What about South Africa? And I think we just also need to reflect on the South African situation. I think it's an example because although we are called low and middle income countries, we're probably somewhere on the upper low and middle income countries, if not upper middle income countries. So if you look at what's been happening is, if you look from 2010, we started having some reduction in maternal mortality. And really, and I'm going to talk about why we actually achieved that. But when COVID came, look what happened there. We suddenly went up. And in 2022, it looks like we're going up, but I can tell you we're very worried whether this is going to be a sustained downward trend. We suspect that we might actually start either plateauing or we might actually start seeing a rise in maternal mortality. And you will see later on when I reflect on what the projection is for South Africa and other countries in sub-Saharan Africa. And this is the slides that I really want us to look at. So if you look at the global, these are estimates of what is going to happen by 2030. So you can see the historical average, the best estimation, and the worst estimation. So you can see, I'm not going to go through this, but you can see those that I've put in green, these are the ones that are likely to achieve that, to achieve the 2030 SDGs. And then those that are in red, those regions that are very unlikely to actually achieve anything. And you can actually see that it's most of those are lower and middle income countries. So we do have a challenge in terms of achieving what we have committed ourselves to do, or what countries have committed to achieve, and the promise the countries have made to women in the global platform. So here is Africa. And again, this is the projection. So you can actually see that from the projection, and this is the one in bracket is the worst case scenario, and the one that is not in bracket is the best case scenario. So you can see that a number of countries, and those that are not here are those that are likely to achieve the SDG goals. So I've taken those that looks like they might be able, from the calculation and looking at the trends, that those countries are likely to achieve. Now, the one that I've put in yellow are those that we're really not sure, which we think they might if they put some more effort to try and address the existing challenges. And you can see the range from the best scenario to the worst scenario. It's a huge magnitude, and it's because the immense challenges that is related to a health system that makes these countries quite doubtful whether they will be able to achieve that. And you can actually see that even South Africa is among those countries. So if we really have to reduce maternal mortality, we might not be able to address the first delay, but we can look at the second and third delay. So we need to look at the health facilities, the healthcare workers that practice in that space. And even if we fail to address the patient level, but we should make some effort. And the key really of this macro level intervention that focuses on the health facilities, the healthcare worker and the patient should really try and reduce maternal and neonatal mortality and stillbirth. I'm not going to talk about the other two because if you reduce maternal mortality, you'll have an impact on the other two. Okay, so if you look at the key strategies, what we really need is to ensure access to family planning. We need to have pre-pregnancy care or pre-pregnancy risk assessment so that we can reduce the risk, identify the women that are likely to develop complication. Having said that, please note that about approximately 15% of women that develop complication through pregnancy do not have any risk factors. So it's really one of the strategies, but it's not the strategy to reduce the complication in pregnancy because of most of them will start without complication and later develop complication. So antenatal care is critical in other ways because this will assist us to identify complications as they arise and also institute preventive strategies like I've mentioned there, the use of calcium, the use of, for example, aspirin. And we need to ensure access to facility deliveries supervised by a skilled birth attendant. It's very important to know that it must be somebody who is skilled. And of course, access to EMOC or emergency obstetric care is critical. That even when we have missed the boat in the first and second delay, if patient comes into our facilities and we're able to provide emergency obstetric care, we'll probably be able to reduce about 70% of maternal mortality. And that's where the health system comes into play. So what do we need to be able to achieve this? If you look at WHO, they suggest that if we can actually provide emergency obstetric care plus skilled birth attendants in labor, we can reduce 88 to 98 maternal death. And that's quite interesting. And I actually look at some data from Ghana, where certain counties in Ghana actually managed to reduce maternal mortality to 0 over a long period of time by just making sure that they provide emergency obstetric care and there is a skilled birth attendants. And that is quite possible even in the era where we've got serious healthcare worker challenges. By looking at the concept of task shifting. In other ways, task shifting is when you develop new cadre of healthcare workers with competencies that enable them to perform tasks that are normally performed by health professionals with higher education or qualifications, or expanding the scope of practice of certain level of healthcare workers. And this will assist us to address the staff shortages. However, in most cases, this is not possible because of the lack of political will and policy support. And these are critical if we have to achieve this. For example, we know that in South Africa, we have trained clinical associates, but to date, there's still no opportunities or very limited opportunities, if any, in the public sector for them to assist in reducing maternal mortality for different reasons. Some is because we as healthcare professionals, nurses and doctors feel that they are not well equipped to perform the tasks that we can, despite that in most areas, even in the US, Mozambique and other of the African countries, there is clear evidence that the clinical associate or physician assistant have actually done a good job in assisting in reducing maternal mortality. And we know even here, and quite interestingly, that we have had this argument all the time of whether a clinical associate can do certain tasks. But we know that when we're in the peak of the HIV pandemic, we have done exactly that. In South Africa, for example, professional nurses were allowed to prescribe ARVs. In Malawi, nurse midwifery, where nurse technicians were trained to provide midwifery services. And Mozambique, mid-level healthcare workers or clinical associate and even nurses were trained to do cesarean sections. And in Rwanda, for example, community healthcare workers were trained to provide PPH preventative services and family planning. And data is there with varying success in different countries. And I think the evidence does support the use of task shifting as a strategy to reduce maternal mortality. I think I cannot complete this talk without talking or referring to technology or ill health and digital tools, which really has proven quite useful, especially at the time of the COVID pandemic. So for example, if you look at the data on access to emergency obstetric care, one of the critical technological advancement that has been shown to be useful is the use of geospatial enabled GPS maps, which assist women and their families to identify health facilities, but also emergency transport services like ambulances to know which is the best road to take. And I saw Prof talking about this at some point, and I think that's quite critical that this, you will know, for example, when I come to work, want to go anywhere, if I switch on my GPS, I will know that this road is probably too congested for me to take. And I think that's where geospatial mapping actually assists in terms of helping us access healthcare facilities. I think I don't need to talk about mobile messaging, say Mom Connect, and I'm going to talk about it from the South African experience in a moment. The use of drones to transport blood product, specimen, for laboratory testing and taking the result back. And you can even send radiological imaging through drones and make diagnosis and treatment of patient timely. We have seen the use of telemedicine during COVID to provide consultations for these remote areas, but also to provide senior support for healthcare workers or junior healthcare workers working in remote areas. The use of electronic record assists, and evidence is very clear that it assists in timers access to patient information that is critical in decision-making and patient management. And of course, decision support software integrate electronic healthcare records with evidence-based literature to guide clinicians as to the possible diagnosis and the diagnostic algorithm and management pathways that they need to take. And I think this is becoming very important. And there are a number of those digital tools that are already available, developed like the Microsoft platform and other areas. And I know some of our colleagues here in Johannesburg have actually started to look at that to assist healthcare workers in maternity services to be able to provide quality care. If we look at the evidence, it's very clear that mobile health is associated with the improvement in antenatal clinic attendance, uptake of breastfeeding and contraception, as well as vaccination. It's very clear that telemedicine has made accessible antenatal clinic uptake. And during COVID, there was no adverse outcome that were observed among those that attended antenatal clinic through telemedicine. I think we're all familiar in the South African context and most South African context of these referral support tools like the Ebola apps. They assist coordination of referrals, even advice for doctors in different places, specialist advice, as well as clinical support and feedback. And data have shown that use of these technologies does assist in decreasing inappropriate referrals in primary healthcare setting, and then reducing overcrowding also in healthcare facilities. I've already spoken on the electronic health record as well as the decision support software or systems. So if we look at a few examples as I'm going towards conclusion, and I'm not going to give you a comprehensive because there's a lot of good practices and evidence out there, but let's look at South Africa. If you look at the graph that I showed you on maternal mortality from 2010 to just 2020, you will see that we were literally on a steep decline in maternal mortality. And the reason for that was because of the strategies that were put in place. The family planning rollout, community-based campaigns using community healthcare workers, provision of free maternity services, and the CAMA that was introduced in 2013, and the improved access to quality health care and education, improving educational status of women, and the IRT rollout, the bank, ESMO, as well as the digital tools that I've mentioned, the national maternity guidelines to standardize care. All of those have seen a decline in maternal mortality. And if you look at the data between 2000 and 2017, we saw a 38 decline in maternal mortality. And however, this was disrupted by COVID, as you have seen, either directly and indirectly. And the evidence is clear that those strategies do work. If you look at Rwanda, for example, and I will really encourage you to look at these countries. The country, Rwanda, is one of a good example of a country that came out of conflict and made phenomenal reduction in maternal mortality. So they went about to strengthen the health system through what they called 4x4 strategy, where they embarked on crippling the healthcare workforce over the 4 years, associated with improvement in infrastructure, expanding life-saving intervention, and increasing the ratio of skilled birth attenders to 1 in 1,000, and compared to the population, the WHO recommendation of 4 in 1,000. And of course, providing mentorship through the Mobimenta, an online system. And this has resulted in 74% reduction in maternal mortality in the last 20 years. And you can actually see that this simple intervention do make a huge impact. If we look at Ghana as the third example, again, family planning, introducing free maternity care policy and national insurance scheme, introducing quality of care framework, which they use the WHO framework, and I've referred to that if you want to look at that. And introducing community-based health planning services, so taking the services closer to the community. And that has really had a huge impact on Ghana's maternal mortality. They might not be on track to meet the SDG, but they've made phenomenal reduction in maternal mortality. And those are some of the strategies that have been shown. And you can see that all of those strategies that I've mentioned, they don't need a lot of investment. So that leads me to the conclusion. And I could have gone in and given you a lot of examples across, but time doesn't allow us to spend, to look at all the countries. But I hope that those 3 examples that I've given do give you an insight of the easy and low cost and accessibility of the intervention that we're failing to introduce or to provide to women. So health systems are critical in reducing maternal death. However, to do so, we need infrastructure, and I think that's where the problem is. We need human resource, we need equipment, we need to make sure that we've got efficient transport system, we need to have evidence-based protocols and guidelines on the facilities at the national level, and of course, we need stakeholder collaborations. The system needs to work together if we're to achieve a reduction in maternal mortality. And I cannot overemphasize the importance of political commitment and will. And I think we all know that in Africa, this is one of the biggest challenges. That even if there is a political commitment in terms of guidelines and policies, the implementation becomes a huge challenge. And in the current era, we need to use digital technology to assist us in making access to maternity care services and life-saving emergency services available to women. And thank you very much for listening.
Thank you very much, Prof, for that insightful presentation. You know, as I was listening to you, so many things were going through my mind, and I have so many questions for you. I don't know where to start. Let's try. Prof, in your opinion, what is the repercussions of us not meeting the SDGs where maternal mortality is concerned?
So I think it takes us back to why, what I've said in the beginning, that why is maternal death important? It's got social impact. It's also got socio-economic impact. So I've mentioned about the impact on the future generation, which is the orphan children. I think you're literally writing off that group of the future generation. But also one thing that I've been mentioning is that when you lose a woman, and the data is quite clear that even on the national level, when a woman dies, you're losing an important contributor to the economy of the country. The contribution that women, and sometimes we forget about that, you know, sometimes in the African setting, we see women as there to bring forth children, but they are major contributors to the economy of the country. But also, if you look at what's happening, and you must look at families that have lost a mother, even the man that is there, when a woman is gone, those men are not able to function properly. And I think that is the huge impact that we actually, when a woman dies, the future generation is lost, but the economic contribution of the women to the country also is lost, and that has got huge impact.
Mm-hmm. And then, Prof, I just want to ask, do you think that the goals that have been set for, you know, MDGs, SDGs, do you think these are unrealistic? Should we maybe temper the expectation and you know, set goals that would be easier to reach?
So there's a saying that if you want to reach the treetop, aim for the sky. And I think sometimes by aiming for the sky, it does help you to put more effort in trying to reduce maternal mortality. Because if you were to set low goals, people are going to be much more comfortable and start feeling, well, we're doing very well. But I think setting those high goals probably do assist in making sure that we invest in reducing the maternal death, which if you actually look in terms of numbers, those are huge numbers. Actually, think of one woman dying every 2 minutes. It's a huge numbers. If that was happening to men, I can tell you that you will see the world standing up, and there will be repurposing of the budget and everything. But because it's a woman, I think there is this whole thing that, well, you know, and I'm not saying that everybody thinks that women are not important, but actually the result of what we're doing suggests that we don't take the women's life very seriously. So I think putting the standard high, and we've seen that some countries actually have done well, and they're probably going to be able to achieve, even in sub-Saharan Africa, because they've taken the call very seriously. So I think I would actually even have aimed for a zero maternal mortality to try and hike the standards so that everybody can put much more effort.
You know, Prof, I mean, I've been reporting on maternal mortality for many years now, and it feels like we're telling the same story over and over again. We seem to know what to do, but it's not happening.
You are correct. And I think it's, I mean, if you look at most of the countries, there are good policies, but what lacks is implementation. So I mean, I was looking in our country, for example, South Africa, the excellent policies. We've got these, you know, wonderful things that we want to do, but those things never get implemented. You know, I mean, we're talking about universal access to healthcare, but you go just to every hospital at the moment, We won't even find a bed. We won't even find healthcare workers. Those are the things that I think makes Sub-Saharan Africa to struggle. And that's, you are correct. We're not going anywhere. It's like a vicious cycle. We just on a merry-go-round. And I think somebody need to come in. I think that's where the country need to come up and say enough is enough. I mean, we have huge impact on the political level. When we want things done, I mean, look, in South Africa, the ETOs, we all stood up and the ETOs are gone. But have we put the same effort in trying to reduce maternal mortality, I think we'll have achieved even much more. But I think it's our value of maternal death or the way we look at maternal death is probably not taken, given the weight that it deserves.
We are almost running out of time, but we do have a question from one of our attendees. Ayola wants to know which group of women are most affected by maternal mortality in terms of age and where they are, because he believes that knowing this will help focus our attention on these most affected areas.
Yeah, so I think if you really look at the group in terms of age, you are looking at the under 20 and the over 35. Those are most commonly affected. And of course, women of high parity. So if you're looking at who is affected, those are the group of women. And of course, women that are living in hard to reach areas, rural areas, for example, and even in areas within cities that have got limited resources. And I think if you're looking at shanty towns and so forth, those are the areas that are mostly affected. So if you really want to intervene, those are the group of women that actually suffer the most. Interestingly, if you look in South African context, we don't really report maternal mortality in terms of demographic and race. But the reality, if you want to know who is dying, it's mostly Black African women. And for some reason, we shy away from saying that. And we also know from institutional mortality that patients that are coming from other countries also suffer the worst within our system. They die. And those things are not actually reported because we don't want to face the reality. So if you want to really single out, and I have been arguing all the time that let's segregate this so that we can start directing our interventions. Because now we put everybody in one basket. And instead, we are actually ignoring the group of women who are suffering the most, especially our patients that are coming from all the other countries because of all those challenges that they're having there. They are the ones who die in our system, as well as the rural and poor women.
Prof, I actually want to try to wrap this up on a bit of a forward-looking, not so somber note. What's the way forward? What can we do?
So I think we've got opportunities. If we look at what I've shown there, we have got the tools to reduce maternal mortality. All that we need to do is to try and work together as a team and put concerted effort to reduce maternal mortality. Try and educate women when they come through to our system. Use every opportunities. I do that all the time. If I get an opportunity to speak to communities, I do that. And so the hope is not lost. All that we need is to all come together, put effort, because the tools are there. And I believe, and I've said this over and over again, that if we all can actually wake up today and decide in Sub-Saharan Africa that we are going to reach the 2030 development goals, we can actually reach that because we do have all the facility, the tools that we need to. So I will want to invite everyone to say, there's this song that says, brighten the corner where you are, that let's all sit in the corner and put effort. And I think collectively, we can reduce maternal mortality. And the 2020-30, 6 years, is not short. It's long enough for us to achieve that. Thank you.
Prof, I'm going to make this the last question for you. We've got a question from the National Department of Health from Joyce Mahunzi. She wants to know what Prof suggests in terms of overhauling our health system, in terms of infrastructure and referral pathways.
Yeah, so that is a very long discussion, which I won't be able, but I'm quite happy I do have some thoughts. on how we can improve this. And I've said in different platforms that the problem with the South African system is the way it's designed, where in principle, the primary healthcare approach is a good approach. And I think most of people in the platform might have seen the work from the World Bank that have actually shown that our biggest problem in Southern Africa is that we have not incapacitated the primary healthcare. So women come in there, then they don't receive the care, they complicate. After they complicate, then they need to be transferred to the next level of care, which usually takes time because the ambulance doesn't work. So if you want to do anything, have got impact, when a woman enters the system, they must get the right type of care at that point to reduce the complication so that there is no need for you to refer them into the next level of care. When they will have severe complication, then need ICU, which is often not available. So that is, we need to revise the way that we've designed the system because that's where the problem is.
Violet, my apologies, Prof. Prof. Jude, I believe that there are a couple of hands that are raised in our audience. Could you please assist us to address Prof?
Okay, the first one is Mary. So Mary, please go ahead. Unmute yourself and speak. Yeah, I've given them access, so if they all could unmute to speak. Starting with Mary.
Since Mary is taking long, Prof, may I please take the opportunity to ask Prof a question?
Okay.
Yeah, it's Dr. Mbodi from Krisani Bara. Prof, the issue of global citizenship and the healthcare immigration, in this day and age, we cannot run away from. And I don't think we need to entertain it in that manner. But I've seen that there's a lot of contribution, no matter how much we change on the infrastructure or we change other tools, we're still going to encounter. On your last comment, you mentioned a little bit about it. I want to know from your side, what can we do to counter the impact? Not necessarily to stop the immigration and global citizenship, we can't. The impact that we're seeing on maternal death that is being brought about by those two factors, what do you think we should do to try and counter that?
Thanks, Dr. Mbodi, for picking up on this very important issue. So I think one of the challenges that, and looking at our own experience where I work, one of the big challenges is that women present late. And I think they present late because the system is almost adversarial, if I have to use that word. So they wait until there's a complication where they're left with no option but to come through. So I think we can make the system more accessible, and it will help us to see patients from the neighboring countries much earlier, where we can identify the challenges. For example, if you look for what is the main cause of death, usually in our setting, it will be HIV/AIDS, as well as existing medical condition. And those are the things that if a woman can be seen much earlier, we can optimize them and reduce the negative impact. And I think that's where the problem is. Let's make the system accessible and welcoming. And I think if we do that, we'll reduce the negative impact. We can't stop women from coming through. And I think you're quite correct in that.
Thank you very much, Prof. Okay, this is really the last question. We are really out of time. The next hand I see is Sylvia. Could you kindly just introduce yourself and let us know where you are so that we could understand the context within which you're speaking? Please unmute yourself.
Yeah, good afternoon. I'm actually Dr. Tsebekulu. I'm at Dr. Josh Mokari SMU academic meeting. We are all in one hall here. So one of my colleagues want to ask the question. So we are from the tertiary hospital here.
Good afternoon. This is Dr. Chokwe. Thank you very much, Prof. Chauke. But I've got a question for you. In your conclusion, you mentioned that what is required mainly is infrastructure. You mentioned staffing. You mentioned just a moment. There is an echo here. They're just adjusting something. Thanks very much. I think it maybe is clearer now, I hope. Prof. Chauke, you mentioned the importance of a few things there in your conclusion, that what is required for us to achieve this SDGs would be, we need we need infrastructure, we need the workforce, and then we need transport services, we need equipment. When I look at all those, I'm pointing a finger at probably the management of the health services, if not the governments. In those countries where maternal mortality rate is high, what is the contribution of the governments in those regions? Because in our country, for instance, where we work, equipment is a problem, staffing is a problem, infrastructure is a problem. The communities don't have transport to come to the hospital. How much is that contributing to this difficulty in attaining as SDG as we are supposed to strive for? I hope my question is clear, Prof.
No, thanks, Dr. Chokwe. So I think, and thanks for asking that question. And that's exactly what I mentioned in my conclusion, that what really lacks in sub-Saharan Africa and Africa in general is the lack of political will. Because if even if you fail in the first delay, and maybe the second delay, if we can have the system, the imaging system in place that is able to provide images of obstetric care, you can actually reduce most of the death because of the fact that those are caused by pregnancy-related condition, and the data suggests that it can actually be up to 70% of that. And we have seen that where the system is in place, maternal mortality in some of these regions has actually even gone to zero, where some people will tell you that it's not possible, but there is actually some examples in Africa that have shown that. So indeed, the huge contribution of the government and the political lack of political commitment into using that. And maybe that's probably one of the key drivers of why we're struggling in Africa to reduce maternal mortality. So there is a huge contribution to that. And until Africa start taking maternal death serious and put their investment in what they say, we are not going to be able to reduce maternal death.
All right. Thank you very much, Prof. I think that your message is clear, well understood, and we all concur. Thank you very much for staying with us this afternoon, and thank you very much for taking more of your time to engage with all of us. And I would like to thank everybody who stayed on the call, who's been engaging. Unfortunately, we won't be able to get to all of the questions today, but I do encourage you to keep the conversation going. It is such an important conversation that needs to live on beyond this webinar and this platform. We are thrilled to have had you with us today and again taking part in this critical conversation. Together, through collaboration, innovation, and decisive action, we can build stronger health systems. And I'd like to also close off on the sentiment left by Prof. Chauke earlier, that we must all clean our little corner, and hopefully little by little we can start to make a difference. Colleagues, thank you very much. From a no longer sunny Johannesburg, it started raining in the time that we've been here. I trust that everybody has a good evening, morning, and rest of the day. Goodbye.
Bye. Thank you.
Bye. Thanks, everyone.